There were two things that I wanted to be sure that we didn't miss out on. One is this concept of trauma-informed care. And I think it's a little bit complicated, but it's really worth a few minutes of your time, and I'm going to talk about it from a physical health provider standpoint.
Yeah.
So the idea that every social worker has known since the beginning of time that the more bad stuff that happens to a kid, the harder time the kid has in their lifetime. And that we've known in the social science forever, but the physical science is finally catching up. The neuroimaging is really catching up with what that means. And so as those traumas accumulate in a kid's life, what we're being able to see now on PET scans and other imaging is it really changes the way their brain develops. And it changes the way that that kid develops their own behavior patterns. How can they comfort themselves? How do they interact with other people? How do they deal with stress? How ready is their brain for learning and for social environments? I think, quite honestly, this is the next germ theory of medicine. As a physical health provider, it would have changed immensely the way that I dealt with my patients. So I ran a free clinic for 15 years, and everybody that I took care of were people who lived in poverty. Being able to really think about their emphysema, their suicide attempt, their depression, through a lens of trauma over their lifetime, I think is going to change the way that we practice medicine.
We know the brain development happens most between 0 and 5, so we're looking at healthy communities of not only healthy eating and active living, but how do you change systems so that at the youngest ages, even before children are born, that they're getting into the systems, that the community is engaged, that they're the first responders in some ways in helping connect community. And that has impacts also on health long term. So it's happening all the way into
A group of kids who have 4 or more what we call adverse childhood events. Their risk of suicide is 12 times higher. The risk of being a smoker is 4 times higher. Their risk of emphysema is 3 times higher. So the question is, so if I have somebody who's a smoker and I know that they fit in that category, am I going to approach their smoking cessation differently than I would if they didn't?
Yeah.
Are the resources, and quite honestly, I will tell you that the physical health science is just beginning to touch this. And it hasn't really caught up with how you deal with it. It's just being able to recognize that, one, I don't want to make the traumas worse by the way I design my system. And how do I help understand that so that the patient can move forward?